Good morning. My name is Elizabeth Phoenix. I'm a nurse practitioner and I work in the Adult Eating Disorder Service of London Health Sciences Centre. Today we're going to be describing the medical aspects of eating disorders, and I'll try to keep it interesting. Our learning objectives for this morning is to talk about how eating disorders develop and what you need to know as family members or loved ones of someone caring for someone with an eating disorder regarding their medical health in particular, and what are the medical implications of having an eating disorder. When we think about eating disorders, we all have certain images in our minds of what we think reflects an eating disorder. And the Diagnostic and Statistical Manual for Psychiatry, that's the DSM-5, outlines the criteria for making a diagnosis either for anorexia nervosa, and there's subtypes: restricting subtype, binge purge subtype, bulimia nervosa, and binge eating disorder. I think for family and friends of somebody with an eating disorder, my takeaway message that I want you to have from today is that when often people think of someone with an eating disorder, they think of someone that they've seen on a magazine cover or on a television show that's skeletal thin and extremely underweight, and that absolutely is an eating disorder. However, the majority of the people that we treat in our program and around the world, 70% of people in eating disorders programs have either a normal weight or above average weight, 70%. So we really need to let go of that lens or that bias that we bring to the idea of what an eating disorder actually looks like. As well, with DSM-5, there was a new category that I talked about earlier, binge eating disorder, and also an eating disorder called Avoidant Restrictive Food Intake Disorder, and we call it ARFID for short. It's less common than the other eating disorders. I'll probably see between 6 and 12 a year out of 300 patients. And sometimes we think about it as that picky eater from childhood or adolescence all grown up, and now they're an adult and are really motivated to expand their palate, but psychologically there's fears that get in the way of doing that effectively. Or it can be somebody who's developed a very strict rules around eating that keep them avoiding certain foods with the belief that it will cause them pain or discomfort or have symptoms of gut and bowel symptoms. So they're often related to some other medical implications that have kind of gotten things going. And finally, there's another category called other specified feeding or eating disorder. And within that, we see atypical anorexia nervosa. Atypical just means not usual. So the individual has all the symptoms of anorexia nervosa. However, they're still normal weight. So they've lost a large amount of weight, perhaps 30, 40, 50 pounds or more, and have all the symptoms of anorexia. However, their BMI is within the normal range still. The other categories are just bulimia nervosa, binge eating disorder of shorter duration, or their symptoms don't reach the clinical level. However, they're still very ill and very impaired by their illness. Purging disorder are people who just vomit and don't binge eat, and then night eating syndrome. It's fairly rare. Night eating syndrome, people are up and eating in the night, obviously, and wake up in the morning to discover packages or remnants or evidence of eating in the night. Sometimes they recall the eating behaviors, and sometimes there's no recollection of having been up and consuming food. It's really important to talk about what are the risk factors for eating disorders, because as family members or loved ones of someone with the illness, you might be thinking about family planning and what that means for future children. It could be, as a parent, you're sort of feeling some guilt, or taking some blame for the development of the eating disorder. And you really need to acknowledge that it's multifactorial, and the vulnerabilities just kind of stack up. So there's no one thing that really puts someone at risk for developing an eating disorder. We know that adolescence is a time for mental illness to rear its head. We know that anxiety disorders, mood disorders, psychosis all develop in adolescence and people start to have symptoms around the time of puberty and mid-adolescence. Eating disorders are not alone, not separated from that. So we often hear from people symptoms started at age 13, 14, and earlier. If there's been some other comorbid psychiatric illness, so often clients with an eating disorder have had an anxiety disorder in childhood, separation anxiety, social anxiety, or all of them. Also, often depressive episodes predate the onset of an eating disorder and make someone a bit more vulnerable. If an individual has had a history of being overweight, being teased for being overweight, so it kind of sets the stage, builds this belief set in their mind that shape and weight is important, because that's the message that gets developed in the context of that teasing or bullying. If the individual has traits that are lean towards perfectionism, social insecurity, or difficulty expressing feelings. So often we find that people with eating disorders, some with eating disorders, are internalizers, meaning they don't really express their feelings out loud, but it doesn't mean that they're not happening in their thoughts and in their emotions. They're just not articulating them or even showing evidence that those emotions are happening. If they've had frequent dieting experiences or focus on body weight and athletic performance, and this can happen quite early in life if people have been in sports or activities where there's a real focus on shape and weight. We all automatically think of things like dance, ballet in particular, gymnastics, swimming, wrestling, rowing, activities where there's often weighing involved and people have to make weight in order to be in certain weight categories. And as people get more competitive in these sports, the vulnerable people, the people who are at risk for developing eating disorders, this is a big factor. If someone sadly has had childhood sexual, physical abuse, or major losses, and finally acute weight loss. We know about 8% of people that go on to develop eating disorders have had some kind of event that led to them losing weight in a very short period of time. This is often like a medical illness, like they've had gastrointestinal illness or surgery that's on the gut or the bowel that's led to long periods where they, leading up to the surgery, weren't well and were losing weight very dramatically. Maybe didn't start eating right away after the surgery because they were sort of feeling unwell. And again, if they're vulnerable, it's going to tip them over into developing an eating disorder. I've seen individuals who've had been on chemo where nausea and vomiting is a side effect, and it's been profound. They've lost a lot of weight in a shorter period of time, and it's tipped them over into eating disordered symptoms. So I like this slide because it really builds a picture of how those previous things that I talked about make sense. So starting at the bottom of the slide, our biology or our genetics is nothing we can do anything about. That doesn't mean we have to be fatalistic or pessimistic about that reality. Like, you know, somebody in my family had an eating disorder, or somebody in my family had depression or anxiety. For sure, I'm going to have those things. That doesn't necessarily mean so. It means that that's going to happen. It does increase our vulnerability, but we can do something with that knowledge. We can do things that are protective and be proactive in developing coping strategies and resiliency and being very self-aware about how we're doing so that we can catch things early and be very preventative. Next, we think about family and school teams, or just places where we live, right? We live within school settings, even our neighborhood. We may spend a lot of time hanging out with a particular family that have a real bias towards shape and weight, or we may have influences in our lives like coaches or teachers that build a belief system around shape and weight and fitness are really key. And it's not to say that those are bad things. It's just for the vulnerable individual, these things land and they stick. We're all very mindful of social, cultural messages. Western society has really had a thin ideal for a very long time. I think there's a big inroads happening with that. It's really promising. And curves and shape that are more normal are really being embraced. However, we do see the impact of social media. People follow celebrities or people that have really done really dramatic things to their shape and weight to modify how they their appearance, and it leads young people or vulnerable people to sort of believe that that's attainable when it's not. And recall from that previous slide, we talked about individual characteristics. Like having being an anxious child, being perfectionistic in their style, and having that proclivity or risk for comorbid other mental illness that sort of set us up and make us a bit more vulnerable. And then finally, the thing that tends to tip it all over, which is a stress event. And it could be a loss, it could be a crisis, it could be trauma, it could be even a really great event, like a wedding, and being the bride and being the center of attention and deciding to lose weight for that. So life event that kind of lights the match at the end of the day. However, the stage has been set with all of these vulnerabilities beforehand. And then the individual starts to gradually engage in eating disorder behaviors that leads to other consequences until they become fully symptomatic and quite ill. Okay, so I want to talk about the Keyes study. And Dr. Keyes developed a study in the US at the end of World War II. And the purpose of the study was to understand the effects of starvation. And we know when we all think about World War II, we think about the devastating images we have of people who were in concentration camps, in prisoner of war camps, even in occupied countries in Europe where people were living on really minute rations for years in duration. And at the end of World War I, there were documented cases of people having sudden access to food and actually dying. And so knowing this, they knew that there were millions of people in Europe in this really deprived state of being starved and underweight and malnourished. And they were really wanting to circumvent that and know how to train the relief workers that were going to go in for the rescue mission. So they designed a study. They recruited men that were conscientious objectors or draft dodgers and gave them the option of being in this clinical trial. So obviously that's not how we do recruitment for clinical trials now. However, years later, they interviewed many of these men and they were really quite committed to the study and really they didn't want to fight in the war, but they certainly did want to contribute to the war effort. For 3 months, they did nothing. They just evaluated them and made sure that they were well medically and mentally. So anyone that had any history of mental illness, either anxiety, depression, addiction, was excluded. Anyone who had any medical issues was excluded. So obviously they couldn't be diabetic. They had to be normal weight. They had to be normal eaters and fit. So at the beginning of the study, there were 37 men who met the criteria, and they reduced what they had been feeding them by 50%. They fed them twice a day, and they fed them that way for 6 months. And they also put them on the treadmill every day, because recall, people in Europe in work camps and concentration camps were working very hard on these small daily rations. So they were trying to emulate those conditions as much as possible. And what happened over the time very quickly is that mood changes reared their heads. Lots of irritability, agitation, their moods declined, they became anxious. And remember, these men were excluded if they had even any history of mental illness. They became very preoccupied with food rituals. They would pre-plan how they were going to consume their food for hours at a stretch. Sometimes they would eat their food rations very quickly and then would cry. Sometimes they'd eat their food very slowly and draw it out. They were adding huge amounts of condiments to their food and making them into interesting little pastes and things, casserole kind of items to make it more interesting. They were leaving the compound to go to school or work, and so some of them would lose control and binge eat, would feel very badly, and then they would vomit. They were withdrawing. They really didn't want to be around people anymore, and their interests became very narrowed. Obviously, when they are losing weight and becoming less well, their energy dropped, their concentration was poor, their judgment was changing. Some of them were actually self-harming by the end of the study. Some of them got down to BMIs that were very low, around 16, and the doctors, the researchers, said to them, "It's really great that we're wrapping this study up." And they said, well, why? And they said, well, we're really concerned about you. You know, your heart rate's low, your blood pressure's low, your blood work's starting to look really unhealthy. And they said, no, I feel fine. They really couldn't see how unwell and ill they looked. And we often associate that difficulty in people with eating disorders to see how ill they are. And perhaps there's a starvation effect, not just the illness or the mental illness that plays a role in this. Multiple physical consequences. So their hair was falling out, their skin was dry, and nails were breaking. And those are the cells that we see on the outside. So we know that cells metabolism has declined, and people aren't making cells the way they should over that 6-month period of time. And that's not just on the outside, that's on the inside as well. So muscle wasting, our esophagus, the tube that carries food from our throat to our stomach, is lined with muscle. So that muscle's wasting there. Our stomach is a muscle, our heart is a muscle, our bowels are a muscle. So all that muscle wasting makes food not pass through our system in the way it normally would. People were starting to have bloating and gas and constipation and a lot of gastrointestinal symptoms. So when we think about this key study, what really stands out when I describe this to families and to individuals with eating disorders is that a lot of these symptoms, or most of these symptoms, really rear their heads in eating disorders. And did they give the men in this study eating disorders? Well, no, they did not. The single thing that they did to them was they starved them. They made them underweight and malnourished. And it's really a great study to teach us about the effects of starvation, because we know that even our patients who are normal weight or even above average weight are starved and malnourished. And so this is a very clear explanation for many of the symptoms or all of the symptoms that they're experiencing. And it increases their awareness and understanding of the impact of what they've been doing as far as their restrictive eating or their irregular eating. And it increases their understanding of the rationale for why we need them to eat. We need them to eat on time. We need them to eat enough. And often they're quite motivated to do this, even though it's difficult, because they really don't like these symptoms. They don't like the symptoms of being low and anxious and not sleeping and wanting to isolate and having poor concentration, thinking about food all the time, and so on. So this is how we set the stage for really building the rationale as to why people need to eat on time and they need to eat enough. The medical follow-up, and often what I hear from individuals while they're being assessed, or even family doctors or the emergency room considering, how are they doing, or do they have an eating disorder, or should a referral be made? And often what I hear is, well, my blood work came back and it was all normal. And so we interpreted that as everything's fine. And the challenge is that the body is so clever, it's so complex, and it's this really highly functioning system. And our body works very hard to maintain normal blood work for a very long time. So although someone might be excuse me, very ill with their eating disorder, very ill with their symptoms, and not well at all as a result of starvation and malnutrition, their blood work can really look shockingly normal for a very long period of time. It's when we start to feed them and metabolism starts and the system kind of starts up and your body starts working that we see the blood work really become impaired. And we monitor that very closely. Once people have assessments in our program, we do recommend that while they're on our wait list, that they have regular follow-up with their family physician, and that will look different for different people based on some of their symptoms and how they're doing and maybe medical complications that they're having, especially if someone is extremely low weight, if they're abusing laxatives or diuretics, or vomiting and purging often. We recommend some weight monitoring, and this might be once a week or once a month while someone's on the wait list. And we teach people while they're in treatment about weight monitoring and how to do so. Blood work, myself as a nurse practitioner, our family doctor that works in our program, and our nurse really set up a process for everyone for blood monitoring. And not everyone needs it as intensively, but we do recommend blood monitoring while people are on the wait list, and certainly while we commence treatment. ECGs, again, are based on clinical presentation. If they've been abnormal, obviously we're going to follow these up and until they're normal, and then follow them routinely thereafter. We do bone density studies as clinically indicated. So what's the 911? As family members, you want to know, when do I really need to know when to kind of pull the trigger and go to the emergency room or call out for an ambulance and so on. If someone's had recurrent fainting episodes, so obviously if someone faints once, we don't tend to go to the emergency room unless it's really profound or they've hit their head or they're really unwell after. Obviously, if someone's had a seizure, definitely go to the emergency room and have them assessed. Heart palpitations are a really common symptom in people who are anxious, people with eating disorders, but it's lasting longer than 5 minutes. It's not settling, and maybe they're having other symptoms that go with it. Shortness of breath or severe shortness of breath, severe chest pressure, vomiting that causes significant amount of blood. It's very serious. Probably call an ambulance, get them to the emergency room immediately. If they're demonstrating sudden onset of confusion, so when people are under eating, often we'll see periods where they're not quite as alert or engaged in what we're talking about. But this is different. This is a sudden onset of confusion. If they've even had demonstrating difficulty forming their words, speaking in sentences, that's not a great sign. And suicidality obviously is something that we take very seriously and want to follow up and make sure that they're assessed and that there's a plan in place to keep them safe. I want to talk a little bit about the serious medical complications of eating disorders, and I want to emphasize that some of these are not common at all. Osteoporosis, and some people will recognize that word. It's when people have bone loss, and often we think about that for postmenopausal women. Even men in old age can have osteoporosis. So it's something we sort of associate with the old. But it's related to hormonal changes that happen with low eating and malnutrition. So women in particular, but men are not excluded, develop low estrogen, and then they stop menstruating or having their period. And what happens when we have low estrogen is that osmosis happens and it draws calcium out of our bones. And that's not the direction we want it to go, obviously. So as calcium leaves our bones, it makes them more fragile, more prone to bone fractures, and arrests people's growth so they don't, if this happens early in adolescence, they may not reach their full height and be short-statured for the rest of their life. Also, we do our height very often in our program, probably every 6 months. And often we repeat it at assessment because bone health, malnutrition can lead to quite a significant height difference for people at assessment. Pancreatic inflammation is extremely rare, but we do see it. Kidney damage, bone marrow suppression, which leads to low blood counts. For example, white blood cells, red blood cells, or platelets. We know that anorexia nervosa in particular has the highest mortality of any mental illness. So it exceeds depression, bipolar disorder, psychosis. And the rates are between 10 and 15% will die as a result of the illness, sadly. And about half is related to the complications of the illness. So physically, their body just tires out and gives up, or half die from the effects of the result of suicide. So here's just another picture what I was talking about. So you see the bone on the right, and it's very clear as you look at that where the calcium's been seeping out of the bone, makes it much more fragile, and people can have fractures in their vertebrae or in their neck or hip, simply standing still or with exercise. And we really caution them about activities that are a high risk for fracture, like skateboarding and skiing and things where we can fall. Okay. So I think you really would have gotten this early on, but I just want to come back to it that eating disorders really occur on their own. And this is really meaning for us as a program and part of the assessment process where we really try to tease out mood disorders such as depression or bipolar disorder, anxiety disorders like panic, social anxiety, GAD, OCD, and PTSD. And we really have a goal of trying to find resources, consider medications, consider treatments to augment the eating disorders treatment so that the individual can actually feel their best as they're coming into treatment. Eating disorders and substance use disorders really do like each other. They come from similar pathways in the brain and travel together. We see in our program regular marijuana use or cannabis use is very common. Recreational substances that suppress the appetite, like crystal meth, cocaine, and heroin, they also increase metabolism or really have a lot of appeal to people who think shape and weight is important and are trying to undereat or limit their intake. Stimulants such as Ritalin and Adderall fall into this category as well. Historically, there was a time in treatment where people would be recommended to have their substance use disorder treated and then they would have their eating disorder treated or vice versa. The difficulty being is it really hasn't worked out. It's very difficult to do that, and often as one illness was being treated, the other would worsen, and so on. And it was this terrible yo-yo effect. And they each would nullify the other's benefit. So really what we try to do now is manage the eating disorder and substance use disorders concurrently. And we do that pretty creatively with doing a lot of things while people are on the wait list, having them use resources within their home community, and working together with addiction services to treat the eating disorder and the addiction at the same time. Do men get to eating disorders? Absolutely, but at a lower rate. Usually it's 1 for every 10. There's a lot of hypothesis about why this happens. We think it's less likely that men develop eating disorders due to their temperament. Their biology is different, obviously. They're socialized in our society in a different way about shape and weight. And we think there also is reduced vulnerability to mood disorders. And as we've been talking about, that increases vulnerability for developing an eating disorder. Men often have different symptoms than women with their eating disorder. They're more likely to overexercise than to vomit to compensate for overeating or out of control eating. There's often a very specific shape and weight that they're aiming for. That's a leanness, muscularity versus thinness. It's about fitness. Are medications useful in the treatment of anorexia nervosa? At this point in time, there has been no research that shows that there are any medications that have an influence directly on anorexia nervosa. However, we do try to treat the comorbidities that may be present that make it more difficult for someone to engage in treatment. So we're often using antidepressants to treat mood disorders and anxiety disorders. We're often using a class of drugs called atypical antipsychotics, which are used for a wide range of anxiety and sleep difficulties, not at low dose, not just for psychosis, and they can be very effective for anxiety and mood symptoms. We know that when somebody is really under eating, there is going to be a low response to medications because the amino acids in foods are really required in order to build neurotransmitters when people are taking psychotropics or psychoactive medications. But we try, but our expectations are moderate. There are some medications that are useful in the treatment of bulimia nervosa, particularly antidepressants in the SSRI category. Fluoxetine is the only medication that's been approved by the FDA for treating adults with bulimia, and it is at high doses, up to 60 milligrams per day. We see that it reduces the frequency of binge eating and purging in about a third to half of patients, which isn't an overwhelming effect. However, if you're in that category, that's a really great benefit. Often what I recommend is getting to that dosage and sitting there for three months to see if the symptoms change. If they don't, then we reduce them down to a lower dose or take them off it completely. Often what clients and ourselves discover is that their mood disorder, their anxiety disorders profoundly improved with the use of the SSRI, and so we often keep them on a lower dose. As family and friends around somebody with an eating disorder, adherence can be something that you can be really helpful with in a supportive way. We all have biases about medications, and that's okay. And we really welcome those conversations in our program for family and friends to express their concerns about side effects or really trying to understand what the benefit is that we're trying to seek with medication trials. As well, we also need to think about how to really ensure that people are taking medication accurately. There are clinical trials that show people who are living at home taking their medications that are prescribed for them take them correctly about half the time, which is a really low number. So they're either taking them the wrong way, taking them at the wrong time, forgetting to take them, taking too little or too much. skipping doses because they haven't had their medication refilled, and so on. The list is endless. So you can see on this slide, I have a medication box, and there's so many wonderful different kinds of dose boxes available now. I really recommend that anybody who's taking even a vitamin, that you use a dose box. I use a dose box. I have everyone in my world using a dose box, and they're really a foolproof method of remembering to take your medications, simplifying the process of taking your medications. If you're taking 2 or 3 different supplements, even 1 or 2 prescribed things, you're opening 5 or 6 bottles at any given time, which is time, and we're all kind of busy. And mathematically, it increases our probability of making a mistake every time we're opening the bottle, right? So if you fill up your dose box with all of your one drug, then your next drug and your next drug, close up the drawers, you're done for the week. All you have to do is pop open the box and you're done once you've taken them. If you can't remember if you've taken them or not, you simply look, and if it's empty, you have, and if it's still there, obviously you still need to take them. Otherwise, you're just guessing if you've taken them or not. And people tell themselves all the time that they remember really well, and the reality is we know from research that people don't recall with great accuracy whether or not they've taken their medications. And lastly, you can tell this is a big pitch. When we fill up our medications, then we realize we're running low. And pharmacies are busy places, physicians, prescribers are busy people. If we fill up 7 days in our dose box and we realize there's 3 tablets or capsules left in the bottle, we call then for the refill, right? And then you've got time to pick it up. Excuse me. If there's no renewal on it, it gives the pharmacy and your prescriber time to get it renewed. Long weekends are a real challenge. And so we really want to commit to taking our medications successfully and accurately. And so not running out is really key. So we all want to know what the outlook is. How is it that treatment's going to impact my loved one, the person I care about? We know with bulimia nervosa, over 10 years, the picture is about 70% have recovered. 30% will remain symptomatic, and we see that at about 20-year follow-up. And 30% remaining symptomatic, they might not be as sick as at their initial onset. They might even have periods of wellness. And then during times of stress, their symptoms pop up again. Sometimes it's like work-related or a stressful life event will occur, and they'll relapse for a bit. Or times of the year, they'll be more symptomatic and so on. Binge eating disorder, because it's a newer diagnostic group in DSM-5, we have less data, but the estimates range from 30 to 60%, which is a big range. So we know that we're still really collecting data. And that's staying recovered 1 to 2 years post-treatment. But, you know, because of the similarities between bulimia and binge eating disorder, we would really guess that the long-term outcome is probably going to be about 70% similar to bulimia nervosa. For anorexia nervosa, if we look at 20 to 30 years out from the onset of illness, 60% will no longer meet criteria, 30% will remain symptomatic. And as we talked about, the range is approximately 5 to 10 to 15% will die as a result, to succumb to the effects of their illness. Suffice it to say, it can be a long journey. Treatment takes time. So what are the main takeaways that I want to emphasize for families and friends of people with individuals with eating disorders, and for individuals with eating disorders themselves? This is a serious mental illness. The medical issues often become much more apparent once we start to feed someone. So it's really important that we don't be lulled into a false sense of security with some normal blood work, even that when we look at the individual in front of us and see that they're really unwell. And the effects of starvation are devastating and last a long time. Thank you for listening to our YouTube video. And there are two other YouTube videos that you can access. One is by our dietitian talking about the nutritional aspects of eating disorders, and by our psychologist really talking about our treatment program and how we organize treatment and what to expect while your loved one is in treatment and post-treatment. Thanks so much for logging on. We really depend on our families and our caregivers and our support people to support individuals in treatment. It really makes a difference. We know from research that people who have good support systems and helpful support systems really do best in treatment. Thank you and have a good day.